Hi, so in this video we will talk about routine newborn care from Marrow 6th edition. Let's start. So in routine newborn care, there are 5 cleans at the birth that we should know, that we should focus on. First one is at birth there are 5 cleans, and first one is the clean hands and wear gloves. Okay, there should be clean surface. Towel used to receive the baby should be clean and warm. There should be clean blade and scissors for cutting the umbilical cord. There should be clean cord clamp, and there should be clean cord. It should be kept dry. Okay, so these were the 5 cleans which needs to be taken care of at the time of birth. Now something about delayed cord clamping. So delayed cord clamping by 30 to 60 seconds results in increased blood flow via the placenta, which decreases the risk of anemia in the later life, right? So the baby will receive more blood via the placenta, decreasing the risk of anemia in the later life. Preterm baby decreases the risk of intraventricular hemorrhage. Okay, so in preterm babies there will be decreased risk of intraventricular hemorrhage. Fine, due to this delayed cord clamping. Okay, this is an important point. Moving ahead, second thing that we need to do in routine care is prevention of hypothermia. Okay, so delivery room temperature should be maintained at 25 degrees Celsius. No free draft of air in the delivery room, and facilitate the skin to skin contact of the baby and mother. This should be done to prevent the hypothermia. Okay, what should be done? Delivery room temperature should be 25 degrees centigrade, no free draft of air, and skin to skin contact. Third thing that we need to do is breastfeeding. It should be started as early as possible after the birth. Fine. Fourth thing is rooming in. Rooming in is what? To keep the baby and the mother together, facilitates the bonding between the mother and the baby, and also helps in the breastfeeding. So what we read first was the 5 cleans at the birth that need to be taken care of. Second one was hypothermia prevention. Third is breastfeeding initiation as early as possible after birth, and fourth one is rooming in. Now fifth one is prophylaxis at the time of birth. So there needs to be certain prophylaxis that the baby has to receive. First one is the vitamin K. Vitamin K, it activates the clotting factor 2, 7, 9 and 10, and it is given IM injection anterolateral aspect of the thigh, and its dose is 1 mg. If the weight is less than 1 kg, 0.5 mg. Fine. What is the dose of vitamin K that needs to be given? Its dose is 1 mg, and if the child is extremely low birth weight, that is baby is less than 1 kg, then 0.5 mg needs to be given. And what does this vitamin K does? It prevents the hemorrhagic disease of the newborn. Okay, now moving ahead to the normal observation in newborn. What is the temperature of newborn? It's 36.5 degrees centigrade to 37.5 degrees centigrade. Okay. Heart rate is 110 to 160 per minute. Respiratory rate is 40 to 60 per minute. Blood pressure is 60 by 40 mm of Hg. Capillary filling time, that is measure of circulation in the body checked over the bony prominence and pivot situs over the sternum, and normally its capillary refill time or CRT or capillary filling time is less than 3 seconds. Fine. So we look at the temperature 36.5 to 37.5, heart rate 110 to 160, respiratory rate 40 to 60, blood pressure 60 by 40 mm of Hg, capillary filling time less than 3 seconds. Now coming to the normal findings in the newborn. So if you remember these conditions, a lot of patients come to the OPD with showing these normal findings, and they are concerned about that. So if you know that these are normal, you can properly counsel the parents. Fine. So what are the normal findings in the newborn? First one of skin and mucosa. Let's start. First one is the erythema toxicum. So erythema toxicum is a misnomer. Now it is called as erythema neonatorum. What happens is erythema toxicum or erythema neonatorum, it is the most common one, and there are red and yellow papulopustular lesions which appears after 24 hours. Fine, see, look, the image is not clear, but you can appreciate, right, that there are certain papulopustular lesions. So these are on microscope, if we do the microscopy of these, we will find eosinophils are present, and the treatment is just the reassurance of parents, right, that this is a normal finding and it will go on its own. Now there is a second condition called the pustula melanosis. There is hyperpigmented patches and pustules appears within 24 hours, and in that the neutrophils are present, and here also we just have to reassure the parents. So we saw two skin findings which are normal. First one is the erythema neonatorum or the erythema toxicum, and second one is the pustula melanosis. First one, in erythema toxicum, red and yellow papillopustular lesions, and in the second one there are hyperpigmented patches with pustules. They both appear within, no, the erythema toxicum one appears after 24 hours and this pustula melanosis appears within 24 hours. In erythema toxicum one, on microscopy we will find eosinophils, and pustula melanosis, what will be seen? Neutrophils will be seen, and the treatment of both is just reassurance of parents. Second one is effect of maternal estrogen. There is white discharge per vagina, there is mucus from the cervix, there will be breast engorgement seen, and there will be bleeding per vagina due to the withdrawal of maternal estrogen leading to the endometrial sloughing. So these all are normal conditions. White discharge from the vagina, breast engorgement, and even bleeding per vagina is also a normal condition because of the maternal estrogen. Because of the withdrawal of maternal estrogen after birth, there is endometrial sloughing in female children, in female babies. Okay, so we saw the maternal estrogen also, effect of maternal estrogen. Third condition is epithelial inclusion cyst and retention cyst, which appears white. So there's something called as the milia. There is white spots around the nose and the face. They are called as the milk spots. On gums we can see bones, nodules. They are the white spots. On the palate we see Epstein pearls. Okay. Now in this image we can see the Mongolian spots. They are hyperpigmented macules and very common in the Indian and Asian people, and you will see this very commonly in babies that will present to you, that these are called as the Mongolian spots, and they are just hyperpigmented macules. Fifth one is the salmon patch, also known as the strawberry angioma or the stork bite or the nevus flavus. They are bright red color lesions also seen in the forehead and the nape of neck. These are also normal findings. Okay, so what epithelial inclusions we saw? First we saw milia, and in gums we saw bones, nodules, and in palate we saw Epstein pearls. Fourth one we saw Mongolian spots, and then comes the fifth one we saw was the salmon patch. Moving ahead to the other normal findings. Small subconjunctival retinal hemorrhages while passing through the birth canal. There can be some conjunctival hemorrhages or the retinal hemorrhages while passing through the birth canal, and this blood will get absorbed from its own from the eye. Hymenal skin tags in the female babies can be seen, and there can be physiological phimosis in the male babies. Fine, so reassurance is the only treatment required for all the normal newborn findings. Fine, moving ahead. Now to head swelling in newborn. There are two kinds of head swelling. We have already read about it. First one is the Caput succedaneum, second one is the cephalhematoma. So Caput succedaneum one, no, that is more common, and its location is subcutaneous plain superficial swelling in the scalp which is diffuse. Okay, so its location is what? Subcutaneous plain superficial swelling in the scalp, and it is diffuse, right? But this one, the cephalhematoma one, its location is its subperiosteum, that is below the parietal bone is the most common one, but subperiosteum means below the bone, and its most common location is below the parietal bone. It is a deep swelling, unlike Caput succedaneum, which was a superficial swelling in the scalp, no, and it was diffuse all throughout. This cephalhematoma is a deep swelling, and it is localized because it is limited by, this cephalhematoma is limited by the sutures. That's why it's localized. Now Caput succedaneum, it occurs because of the prolonged labor, because of congestion of the scalp veins leading to edema, but the cephalhematoma one occurs due to the instrumental delivery or trauma to the skull. If there is any trauma to the skull, then there will be the cephalhematoma one, and prolonged labor, congestion of the scalp veins leading to edema. Now coming to the content. In Caput succedaneum, the content is the fluid, and in cephalhematoma, from the word itself, it's hematoma containing blood. Fine. Appearance, This appearance of the caput succedaneum is at birth or soon after the birth, but this cephal hematoma, in which the instrument delivery was the most common reason, slowly increases over the period of 12 to 24 hours after the birth. This caput succedaneum takes less time for disappearance, that is 48 to 72 hours, but the cephal hematoma takes around 3 weeks to 6 weeks, around 1 month for disappearance. Associations: there are no certain associations in caput succedaneum, but in cephal hematoma, 5 to 25% linear skull fractures, jaundice from heme breakdown from the bilirubin. These two findings will be seen in cephal hematoma. So cephal hematoma is a more serious condition. Okay, more serious, I mean comparatively to these head swellings, cephal hematoma is the more serious one. It's localized due to this instrumental delivery containing blood, and it takes 3 to 6 weeks to disappear, and jaundice may occur because of this heme breakdown. Yeah, right, moving ahead to the subgaleal hemorrhage, which is the most severe one. So this subgaleal hemorrhage, this appears beneath the galea aponeurosis associated with the vacuum assisted delivery. Okay, so this subgaleal hemorrhage, it is associated with vacuum assisted delivery, and there is diffuse accumulation of blood. Okay, this subgaleal hemorrhage, there is diffuse accumulation of blood, and it can lead to hypovolemic shock. They can be pallor due to the decreased circulating volume, and jaundice. There will be lysis of blood. Fine. Now head swelling summary. Whatever we read just now, that caput succedaneum, it is a superficial diffuse collection of the fluid. Fine. This subgaleal hemorrhage, it is superficial diffuse but collection of blood, and this cephal hematoma, it is deep and localized because it was bounded by linear sutures, and it is collection of again blood. Fine, because yeah, we can see, right, hemorrhage, hematoma, which is blood. Moving ahead to neonatal reflexes, also called as the primitive or the immature reflexes: asymmetric tonic neck reflex, rooting reflex, palmar grasp reflex, forward parachute reflex, or the protective extension reaction forward. First, primitive reflexes, they disappear after the brain matures, generally persistent throughout the neonatal period, but few exceptions. So first reflex that we are going to talk about is the palmar grasp. Its onset is around 28 weeks of gestation, and it is fully developed by 32 weeks, and duration of the palmar grasp is 2 to 3 months after the birth. Second one is rooting reflex, attachment and sucking while breastfeeding, 28 to 32 weeks of gestation. It's the onset. It is fully developed by 34 to 36 weeks of gestation, and its duration is less prominent 1 month after the birth. So it is present till 1 month after the birth, and after that it's less prominent, rooting reflex. Morose reflex, seen only in term babies, 28 to 32 weeks of gestation, and it is fully developed by 37 weeks of gestation by term, and it is present till 5 to 6 months after the birth it is present. Fine. So morose reflex is present till 6 months after the birth. Coming to the asymmetric tonic neck, it starts by, its onset is 35th week of gestation, and it's present till 1 month after the birth, and it persists till 6 to 7 months after the birth. This asymmetric tonic neck reflex, it is persistent for more time than the morose reflex. Morose reflex is present till only till 5 to 6 months, right? And this asymmetric tonic neck reflex is present till 6 to 7 months after the birth. Now this parachute reflex, its onset is 7 to 8 months. It's well developed by 10 to 11 months, and this parachute reflex persists throughout the life. Okay. Moving ahead to components of the morose reflex. So what happens in the morose reflex? There will be extension, then abduction, followed by flexion and adduction with cry, with or without cry. Okay. Now there are certain abnormalities of the morose reflex. Abnormalities, first one is that the morose reflex is absent only. So it can happen in anomalies like anencephaly or hypoxic ischemic encephalopathy, HIE stage 3, morose reflex will be absent. Second one is there is only unilateral Moro's reflex. So it can happen in any nerve injury, like if any brachial plexus injury is present in Erb's palsy, or any bony injury like the fracture or dislocation. Most common is the shoulder one, and most common fracture at the time of birth is fracture of clavicle. Fine. What is the most common fracture at the time of birth? It's fracture of clavicle. And if there are the third problem with the Moro's reflex can be that the Moro's is present even after 6 months. So that this Moro's, if persistent after 6 months, it indicates immaturity of the brain, which is seen in cerebral palsy. Okay. Okay, so we were talking about abnormalities. We saw the abnormalities of Moro's reflex. Then asymmetric tonic neck reflex. What happens in that? If the head of the baby is turned to one side, the upper limb of the same side will extend while the other upper limb becomes flexed. This is what happens in the asymmetric tonic neck reflex. And in the rooting reflex, there is stimulation of the baby's mouth, which causes the mouth to turn in the direction of the stimulus. Okay. What happens in the rooting reflex? There is stimulation of the baby's mouth, and the baby turns his or her mouth to the direction of the stimulus. Now the reflexes appearing after the birth, or the infantile reflexes, its mnemonic is special because they are appearing after birth. No, so first one is the parachute reflex we saw, right? It appears around 8 to 9 months, and it was well developed by 10 to 11 months, which was the protective extension forward and prevents the head from falling down. This was the forward parachute reflex. Second one is the symmetric tonic neck reflex, also known as the crawling reflex. So what happens in this one is neck extension, upper limb extension, and lower limb flexion. We can see in the image, right? There is neck extension, there is upper limb extension, and there is lower limb flexion. So after that there is neck flexion, and on neck extension this was what is happening, and on neck flexion upper limb flexion takes place and lower limb extension takes place. It appears by 4 to 6 months after the birth. Okay. And its duration is 8 to 12 months after the birth. It helps the baby in crawling. So this asymmetric tonic neck reflex that we saw here, right, it develops around 1 month after the birth, and it was persistent until 6 to 7 months after the birth. And this symmetric tonic neck reflex, the time when the asymmetric neck reflex was disappearing, it appears after asymmetric tonic neck reflex, and it helps the baby in crawling, and its duration is 8 to 12 months after the birth. Now third one of the special, which the reflexes present after the developing after the birth in the infantile period. Third one is the Landau's reflex, that is on horizontal suspension. There is on flexion of the neck, there is flexion of limbs. So on extension of the neck, there is extension of the limbs. And this appears by 3 months, and duration is 9 months after the birth. Okay, this was Landau's reflex. So yeah, this was all about this chapter of the routine newborn care. Thank you.